So let's talk about peptic ulcer disease. So these are ulcerations of gastroduodenal mucosa that has a tendency to be chronic and recurrent over time. Can be duodenal or gastric. So clinical features under the duodenal ulcers, you may present with epigastric pain, typically at night and when hungry. May present with the first time with a complication, with wide individual variations in symptoms based on food given them pain. So 95% of duodenal ulcers are caused by Helicobacter pylori, that is H. pylori, while in gastric ulcers, we present with epigastric pain, which worsens with food, which is opposite from the duodenal. All the other symptoms are the same. So for the investigation, one is supposed to do stools for occult blood, barium meal, upper gastric endoscopy, where available endoscopy of the gastric mucosa for H. pylori can also be done. How do you manage this? You manage this by encouraging the patient not to eat foods that are a trigger to causing pain when ingested. So avoid obviously acidic foods and drinks such as cola drinks. Limit alcohol and smoking. Advise bed rest when one gets an attack. One should not take NSAIDs, those are non-steroidal anti-inflammatory drugs, which can be a trigger for peptic ulcer disease. Can trigger one to get much more pain. Give magnesium-based antacids or combined magnesium aluminum compounds. So liquid, preferably a maximum dose of 6 tablets a day. So you're supposed to adjust the dose to meet the limit levels to reduce the levels of pain. So if no response, you give cimetidine 800 milligrams or ranitidine 300 milligrams nocteth for 4 to 6 weeks. And then you can manage with 400 to 150 milligrams respectively over time as a maintenance dose. So the aim for the H. pylori eradication has triple therapies. So regime one, you can give omeprazole, clarithromycin, and amoxicillin for 14 days. Second regime is omeprazole, amoxicillin, and metronidazole, which can also be given for 14 days. The third regime is by using PPI such as esomeprazole instead of omeprazole. So you admit the patient in case they need any surgical interventions, which can be triggered by intractable hemorrhage for more than 5 units of blood in 24 hours. Also recurrent bleeding after non-surgical management during some hospitalization. Also, in case there's any cases of perforation, penetration to the pancreas, intractable ulcer pain, suspicion of malignancy, especially in gastric ulcers. Gastric outlet obstruction is another factor for surgical intervention. Complications can include hemochromatosis, obstruction, perforation, penetration to the pancreas, and malignancy.